Hi, everyone. I'm Lauren Johnston, the Senior Program Officer with the Melanoma Research Foundation, and just want to welcome everybody to this afternoon's session. We are really excited to have members of MD Anderson Cancer Center in Houston's team, and they are going to be doing some question and answer sessions with us. First, what I'd like to do is just have each of our speakers introduce themselves, tell you who they are, their position at the Cancer Center, and then we will get started with the question and answer session. So let's start with Dr. Gombos.
Hi, everybody. Thanks for joining us live, and welcome virtually to Houston, Texas. We're sorry we can't welcome you personally here physically, but really want to congratulate the organizers on doing something very unique given the COVID situation. I am an ocular oncologist, so I did my training in ophthalmology and then did 2 fellowship trainings in ocular oncology, one at UCSF and one in the UK at Moorfields and St. Bart's. And I joined MD Anderson almost 20 years ago. And I currently serve as professor and chief of the section of ophthalmology.
Welcome, Dr. Gombos. Thank you for being here. Let's go to Dr. Sheff.
Hi, everyone. Thanks for joining. I'll echo Dr. Gombos' welcome as well. I'm really glad to be part of this organization and part of this event. I'm looking forward to answering the questions you guys may have. But to introduce myself, my name is Rahul Sheth. I'm an interventional radiologist at MD Anderson. I've been here for 5 years now, and I did all my training before that in Boston. So I'm a little bit adjusting still to the warm weather down here, but looking forward to this session.
Thanks, Dr. Sheff. And now we will go to Alan.
Hi, my name is Alan. I am a licensed clinical social worker here at MD Anderson in the Melanoma and Skin Center. I've been here for about 5 years, and so I am happy to be here today.
Great, welcome everybody. So we're going to get started with some questions, and then hopefully we'll start having some pop up in the chat, and I will moderate those. So to start with, let's go to you, Dr. Sheff. Can you tell us about your team at MD Anderson Cancer Center and how you impact those that are diagnosed with ocular melanoma?
Sure. So like I said, I'm an interventional radiologist, and what that means is we do minimally invasive procedures using image guidance. So as opposed to doing major surgeries where there's large incisions, we use small needles through the skin to try to accomplish similar goals. And we do all of this with sort of state-of-the-art imaging. And so the type of procedures that we offer for patients is kind of breaks down into 2 categories. One is diagnostics. So some of it is getting tissue. So for a lot of the diagnostic studies and a lot of the clinical trials, many of those decisions are based on the type of tissue that we acquire. So that's a sort of a major part of what we do. And the other is the actual therapy side. So when the tumor has spread to other parts of the body, we can deliver focused therapies right to that spot to kill the tumor right where it is without having to resort to a major surgery to resect it. And so this is something that we offer, essentially from head to toe. And is a very common way in which we intersect with patients with ocular melanoma.
Great, thank you. And real fast, can you just tell us what would be an example of one of those treatments or surgeries that you happen to perform?
Sure. So by the nature of the disease, a lot of the things we do are directed towards the liver. And so we can do just about anything you can imagine. Since we can get our needles and catheters right into the heart of the tumor, we can burn it with heat, we can freeze it with cold, we can deliver high dose radiation right into it, we can deliver chemotherapy right into it. So, and we do all of these things. So it's sort of, we're kind of like the FedEx. We can get whatever you need where it needs to go.
I like that analogy. Thank you. Let's hop on over to Alan. So Alan, you said that you work with the melanoma in the Skin Center, and just wondering what types of services does your team offer those diagnosed with ocular melanoma at MD Anderson?
Good question, Lauren. So as a social work counselor here, on a general sense, my role is to support patients And that kind of means wearing a few different hats sometimes. A lot of the things that I do kind of revolves around counseling, kind of just helping with coping, either individual counseling, family counseling, kind of working with anxiety, kind of depressive feelings sometimes. Sometimes it requires or kind of has me kind of providing kind of support for how do I talk to my children about my diagnosis. And then also kind of just relationship and safety. Another big portion of my role is to kind of try to help facilitate the conversation with advanced care planning, advanced directives, kind of legacy planning, just kind of having patients be very actively involved in their care. As well as big portion is resource linkage, getting connected with community resources. So trying to figure out logistics of coming to Houston, where to stay, if you're not from here. Is it close by? Are they offering medical rates? How long do I need to stay? And then kind of just maybe even kind of problem solving some financial barriers. Sometimes helping navigate between kind of patients who are still actively working and trying to seek treatment and kind of what their rights are as employees. And then we also do offer survivorship resources and support groups.
Great, thanks, Alan. I hope that some people are able to take some of that information and realize that really you're a resource in so many different ways, not just a therapeutic resource, but you have your hand in a lot of different areas for them. So thank you. And so last but not least, let me ask Dr. Gombos a question. Can you tell us a little bit about how your role intersects and plays with maybe Dr. Sheth's team and Dr. Patel's team in regards to ocular oncology? Oh, you're on mute, Dr. Gombos, sorry.
Better? Yeah.
Perfect.
Those of us that go into ophthalmology generally go into a discipline that is fairly isolated from the rest of the medical disciplines. Most people go to their eye doctor not within the setting of a big center or a big, facility. They'll usually go to their local clinician. They may go to an eye clinic. But as with all aspects of cancer care, no one person can do it alone. You have to look at the patient holistically. And one of the things I truly love about working at this institution is the multidisciplinary aspect that a patient may not appreciate, that they may be in my office, but they're actually interacting with a group of experts all the time because we're all talking to each other. We're all interacting with each other and we're all advocating for the patient at a different level. And so if a patient comes initially to me and I make the initial diagnosis of having a uveal or a conjunctival melanoma or some sort of ocular melanoma, that gets everything shifting in a pattern where I order scans and I have a neuroradiologist who does nothing but read scans of cancer patients. I interact with a radiation oncologist who's a specialist in ocular brachytherapy, the plaques and the radiation plants that are unique to the eye. And then after we do prognostic testing, it goes to someone like Dr. Sapna Patel, who is unique in the sense that she works in a department of melanoma. I mean, how amazing is that you have a department in an institution that is focused on melanoma. Every faculty member does nothing but melanoma. And within that, she is the expert for ocular melanomas. I mean, a disproportionate part of her care is just for patients with ocular melanoma. It's almost unheard of. It's very unique. And then she can then, if a patient, develops metastatic disease, then go down the next Christmas tree. Do they benefit from seeing someone like Dr. Sheth for directed liver therapy? Does she need to interact and provide her own care for high-risk adjuvant therapy, or does she give immunotherapy? Or is it a situation where she has to access our phase 1 team? So at every level, that patient interaction is actually interacting with 20 other experts who are doing nothing but focusing on that patient's care. And I want to get to the social work side of it too, because if a patient reaches out to Dr. Patel or myself and says, I'm having this issue or that issue, well, we're already on top of it, and we're already communicating with our members in social work and other parts of the team to sort of support that aspect of their care as well, because that's as important as any other, part of the cure. It is all these other components coming together, and I think that's what I love the most and cherish about being at a place like Anderson.
I really love the team aspect, and that it really is a team, not just an individual specialist. So thank you for really highlighting that for us, Dr. Gambos. So I have a question from the audience, and Dr. Gambos, I'm going to direct this one at you, if I may. So the question is there any definitive time where someone can say that they're cured from ocular melanoma, or is this just the nature that you'll always have to have scans?
Yeah, it's a great question. And I know that everyone with cancer likes to hear this: you're cured, you're done with it, now it's time to move on. And unfortunately, we don't do that. And the reasons is nothing is absolute in medicine. And the more you're involved with the disease, you also see outliers. And so a lot of times, first of all, in cancer management, you often hear this concept of 5-year survival. It's very common because a lot of studies for various cancers will talk about what's the likelihood of surviving a disease after 5 years. That model is not great for a disease like uveal melanoma. And why is that? Well, we're great at treating the eye. I mean, sometimes we have to remove the eye, sometimes we lose vision, but we can control the disease in the eye in some way, usually, often by preserving the eye. But that isn't linked to prevention of spread. And sadly, we've all experienced patients who develop spread 5, 10, 15, I've even seen 20 years later. Now, with every year that you move on and you don't have disease progression and there's no disease elsewhere in the body, your odds are improving that you're going to be one of those long-term survivors. But we never keep it out of our heads that you're one of those patients that could potentially relapse, because we've seen people relapse years, even a decade or two later. So what you'll often find is, and the approach that Dr. Patel often takes is, we heavily scan patients within the first 10 years. We used to stop actually after 10 years, but again, because we had patients who would still present even after that, we've continued to scan our patients for up to 15 years, particularly those that prognosticate to have a high likelihood of spread. And then after that, Dr. Patel may discharge them from Anderson, but I always tell patients, you must tell your PCP, you must tell all the doctors that you're interacting with that you have survived this cancer. Don't keep that out of your medical history. Don't just say they don't need to know about it, because things do come up and it's rare, but it may be relevant in the future. That doesn't mean we're not optimistic. That doesn't mean that we're, not hopeful that you're behind all this, but your doctors need to know about this history. And so in my practice, I watch the eye for a good 10 years. And after that, I discharge the patient back to their local retina person. But I've seen tumors in the eye come back after 10 years as well. So I always say, even after the eye looks great, after 10 years, you need an eye exam at least once a year.
Thank you, Dr. Gambos. So appreciative of that overview. Dr. Sheth, there's a question that I think that I want to start with you, if this is okay. What do you find the most hopeful aspect of your work with ocular melanoma patients, and what do you find to be the most challenging?
That's a very interesting question. So I think the most hopeful thing about melanoma, ocular melanoma, is the progress that we made, in terms of not just local control, but also recurrence reduction and treating it with systemic therapies. So a lot of the work that Dr. Patel, I know she had a session today on trials, things that are really up and coming, I think are very, very exciting. And the key thing is sort of what we are able to offer here at this institution. So like Dr. Gumbo said, we have a very unique environment in which to care for these patients. And part of that is the clinical trials sort of world that Anderson lives in. And that's really one of the pillars of this institution, is the sort of treatments that we can offer and these therapies that we can evaluate that are unique to this institution because of the massive infrastructure for our clinical trial operations. And so that's, I think, really what gives us the most hope about this this disease and the treatment paradigms that we have nowadays and what's coming in the future. And I wouldn't say there's anything that is unique about this cancer that is leading us to believe to be disparaged about it. But like Dr. Gumbo says, vigilance is key. There's no time at which point you should take your eye off the clock. You have to stay focused with imaging and with follow up, and that way just make sure that that we stay on top of it.
Thank you. And Alan, I want to direct that question to you as well, since you work with patients on that other spectrum, not the medical piece, but on the social emotional piece.
So I guess on the social emotional aspect, I think that the most hopeful aspect is that a lot of the patients I work with and come in contact with ocular melanoma are very so knowledgeable about their diagnosis and the treatment and just kind of what options and information is out there. A lot of times I'm learning a lot from them. And so just to get a better because it helps me because it gives me a better understanding of where they're coming from, where they're at in their cancer journey, just kind of coping wise, so that way, we can start on that area. We're all at the same place when we're working on kind of just doing that counseling piece of it. And one of the most challenging is that I feel is that a lot of our patients just kind of feel like it's hard to connect with others sometimes. I think that this whole pandemic has made things a lot easier with moving forward with like virtual support groups and symposiums like this, where it may not have been kind of easier to connect with other ocular melanoma patients beforehand, or it was very limited. So I think that was one of the barriers and challenges. And I think that that's one of the good things that came out of this is that it's opened that doorway to help connect people of this community. And I think that a lot of people are thankful for that too.
Thanks, Alan. I really like how you have spun a pandemic where I think most people see it as very negative is actually really positive for this rare cancer community. So thank you for reframing that way. I think that was fantastic. We have a question that hopefully Dr. Gombos or Dr. Sheth, either one of you could answer. What kind of communications or interactions do you at MD Anderson have with other OM treatment centers? Dr. Gombos, you're muted again.
With any rare cancer, there's a small cohort of clinicians who are involved with it. And, we have the American Association of Ophthalmic Oncology and Pathology. We have the International Society of Ocular Oncology. We are, by definition, a small group. And we really all know each other around the country and around the world on a first name basis. And we interact with each other all the time. I have a text chat that I use with a number of my colleagues on both coasts. We talk about difficult cases. We talk about protocols that are out there. We talk about, what they're offering in their centers. We interact prior to the pandemic, but even now at very specialized meetings. We just had the American Academy of Ophthalmology, which is the national meeting for eye specialists across the country. They had a dedicated session on eye cancers, which they always do, and a whole session which Dr. Patel and others spoke at. And so the nice thing about this is it really is a very tight-knit group. We're all collegial. We're all in this together. They're really, you know, there's no competition is not the right word. We all just want to get to the answer and cure our patients. And you'd be surprised how behind the scenes where there's enormous amount of collaboration. I see one of the questions from Dr. Selig is, you know, how do we interact with our basic scientists? So our team actually has a monthly uveal meeting, and that's open to anyone who's dealing in any aspect of the uveal group, whether it's the clinical side, the surgical side, the interventional side, but most importantly, the research side, because that's where we have interaction with the basic science labs and the translation labs. And I learn a lot because I learn what they're excited about. And I was never raised as a basic scientist, but as a clinician who's equally frustrated that we don't have the cures that we have, I look toward our basic scientists and I say, you know, this is the challenge. What can you do? And they get excited hearing about, oh, well, look at this patient. They had a great response to this drug, or look at this situation, or look at this study. We'll have what's called a journal club, where we'll present a paper from another group, another lab, and then we'll talk about it, you know, and how relevant is that to what's going on now. The challenge is it's a rare tumor. Funding is always a challenge for research. We're very grateful for CureOM and MRF for the funding that they have provided. It's very helpful, really very helpful for a rare disease like this. It gets money into the basic scientists that frankly is harder and harder to get. So I can assure people it is a full circle.
Thank you. And I guess I just want this next question to kind of go along with that is, and maybe Dr. Sheth, you can speak to this, is, or either one of you, but how is MD Anderson able to attract and run so many clinical trials versus other institutions in the States?
So I can talk about that. So I think a lot of it just comes from the institutional commitment to it. To run a clinical trial takes a lot of infrastructure. It takes a lot of manpower, organization, administrative staff, let alone the recruitment and the clinicians and nurses and the research team itself. And for decades, Anderson has invested the requisite resources to build this infrastructure. And as a result, it has become a sort of a center for these trials to be run because of the efficiencies that we can bring with all the effort that's put into it. So it's not by accident that we have all of these trials and we're able to offer these sort of innovative treatments. It's through a lot of dedication, hard work, and sort of forward vision from generations past. And I think in and of itself, in addition to attracting patients, it attracts physicians and caretakers, because when I was finishing my training 5 years ago, I looked around the country and was thinking about where I should go. And I'd never really been here before at MD Anderson. And when I came here 5 years ago, I mean, that was it. I didn't have to go anywhere else to go visit. And this place really blew me away because I knew that I would be able to do the sort of cutting edge innovative therapies that I was interested in, here far more than anywhere else. And so this, this was exciting, not just for what we could offer the patients, but also for those of us who could deliver the therapies.
And I would add to that, when you're looking to practice, Anderson just is, it's that bee going to honey for the doctors. Those that have a calling in oncology, particularly academic oncology, this just is an environment where you want to be at. We all want to care for patients. Every oncologist wants to save every patient that they can. But then there's a cohort of us that say, can we do better? And that's what academic medicine is all about. It really is about taking it to the next level. If we can cure you, can we cure you with less toxic drugs? If we can't cure you, what can we do to cure you? And the understanding that it can't be one person. It has to be a laboratory-based environment that goes translationally, that's based on basic and clinical science, and then goes to the clinical aspect. And as Dr. Sheff says, this place was just designed with that intent. So everyone that comes here is wanting to do that, because that's why we came here. Agop Badikian was a medical oncologist that preceded Dr. Patel and worked in the melanoma department for 40 years, and and anyone who's senior enough knows that for decades he ran clinical trials for uveal melanoma when no one else would, because this was the place that was willing to provide that milieu, that support for that. And then we, Dr. Sheff, I, Patel, medical radiation oncologists like Dr. Morrison, and all, we just filled in that natural gap, that natural environment. We said, can we be part of this? And it's sort of like a carbon atom that just gets bigger and bigger, or like an ice structure that just gets bigger and bigger, because you feed off of the excitement. Someone has, people ask me all the time, Dr. Gambos, the doctor told me that the prognosis is not good. What's your thoughts? Do you have hope for the future? And I say, I look at oncology, I wouldn't consider myself old, but I'm definitely sort of mid-career, where I think I have some perspective. And you look at the advances of pediatric leukemia, where, John F. Kennedy's, Bush's daughter died of leukemia, and today she would have a 90% cure. You look at cutaneous melanoma, and you look at someone like Jimmy Carter, who is alive today, wouldn't have been alive 20 years ago. And so you feed off of that and you say, my God, look at all these amazing advances. I have no doubt in one day we will have an absolute cure for uveal melanoma. I don't know when, but when you see how far we've come with other far more debilitating, serious, life-threatening cancers, you feed off of that, and you know that there is going to be major advances. And we have already made major advances. The prognostic testing that we have today in uveal melanoma is second to none compared to other cancers. Other cancers would die for a great prognostic test, for lack of a better term. But it's such a great prognostic test, and we have this for this rare cancer. How wonderful is that? So, all of us here, we're all dealing with tough diseases, but we feed off of each other's energy, and we love being here.
I love your enthusiasm. So you've sold me on MD Anderson. Thank you. But just, I love that that both of you again talk about like this team atmosphere at your institution, and that you feed off of your team and off of the atmosphere from other institutions. And I just think that that's such a great feeling and emotion to have and to see from the outside, and that you perpetuate that from the inside of your institution. Dr. Gambos, there was a question that should people continue once they've been diagnosed with ocular melanoma wearing UV protective sunglasses?
Yeah, it's a great question. It's one that often comes up in our meetings. So everyone knows that with skin melanoma, cutaneous melanoma, there is this great relationship between sun exposure and developing the melanoma. And people are often questioning what's the merits of that as it relates to uveal. Do we have evidence that uveal melanoma in particular is associated with that exposure? And, the science hasn't really borne out. The Australians are probably the best cohort to look at, because in Australia, you have a very fair-skinned population that was plucked from, the United Kingdom and moved over a century to a very light-intensive continent, and their rates of skin cutaneous melanoma are disproportionately high because they have a high-risk population. But their rates of uveal melanoma, intraocular melanoma, are not disproportionately high. And there really has not been data that shows that UV exposure is a risk. Now, is there benefit in wearing UV protection around the eye and sunglasses? I can't say that there's any harm, but there isn't, the definitive proof that it's beneficial. And over and over and over, I really would say that it's really important to tease out what we know for certain and what we don't know for certain. And there's no evidence, conclusive evidence that UV protection is helpful for uveal melanoma. Now, for certain conjunctival tumors, it's a different part of the eye, and I'm not talking about melanoma, I'm talking about like squamous cancers. There may be some better studies that suggest UV exposure may have a role. And no one's going to argue that, there's benefit in wearing glasses. Some people have questioned whether it helps with prevention of cataract formation. So it's one of those things, do no harm. And I don't think it's going to cause any harm, but I wouldn't spend $1,000 on a pair of glasses for that magic protection.
Great, thank you. Alan, I have a question for you. I think that sometimes when people are diagnosed with any type of disease, often sometimes they'll look for help, but other times they just kind of want to go through it on their own. And they also don't want to look weak by asking someone for mental health services. What would you tell people? What is your advice? How does MD Anderson kind of stomp out that perception that asking for that emotional support means that you're not a fighter?
I wish there was a way that everyone could see how many other people feel that way, because it doesn't take me long to figure out when I talk to somebody. So just kind of when I get referrals about kind of like helping make things work, like I'll get a referral from the team like, hey, we'd like to have this patient come every few weeks, and then the medical team will work with me, like, how can we make that happen? They're saying that, the cost of travel, lodging, and all that. So after working through the logistics, I kind of do just check in with them, like, how have you been dealing with all of this, and, the amount that people unload is like, well, like I've been trying to figure all this stuff out and no one, I just didn't want to, I don't have time to kind of process or just to feel down about myself or feel down about the situation. I just have to figure out they're constantly in survival mode. And so just just letting them know that this is a safe space, or it's okay to have those feelings and emotions and just to process, and to also even set some time apart to do that. And just to know that I just wish that they could see that how many other people out there feel the same way, that they just feel like they don't want to get bogged down with the emotional portion of it, and that they feel weak for even admitting that they feel a little bit down or anxious. And so I guess that's just the part for me, is just realizing you're not alone. And I tell people that, participating in support groups doesn't mean you have to come in and just even talk. Sometimes it means just coming and observing. Sometimes being a part of a support group is more than just coming and sharing and talking, because we understand there's people out there that aren't those, that don't like to be that open and share, but coming to a support group and just listening to others helps kind of break down that wall that you're not alone, hearing that other people are also going through the same thing, and normalizing all that feeling of, depression or anxiety or just feeling alone, kind of makes it a little bit easier to talk about. So I think that's one of the big things, is that just to have the courage to bring that up to either your medical team, social worker. Eventually that information will get to the right person to kind of help process all of that.
And how are people referred to you, Alan? So if someone is in the clinic, how are they recognized to be like, hey, we need to send them to Alan?
So a part of my role is educating the medical team about what I do. And so whenever they get information like, oh, when someone says like, I haven't been feeling kind of well, or they feel like what's great about the team here at MD Anderson is that because we all work so closely together, they listen out for those red flags or key information, like, hey, can you reach out to this family? I get some information from the medical and he's like, can you reach out to Mr. John Doe? His wife is having a really difficult time kind of processing this information, or they're needing him, or they're like, hey, they don't know where to stay. Or they're like, hey, they're having issues with kind of their employment. We have information out there, just kind of advertisement here at MD Anderson about social work in general. But I get and then there are some people who just kind of have heard about it from their own local hospitals. Like, my social worker over here helped me. Like, what can you do for me at MD Anderson? And just educating that, there are some similarities between what social workers do in a general sense, but, specifically what can I do as an MD Anderson social worker that your other social worker may or may not do? Or, how can we work together to kind of bridge that gap?
And can you maybe explain the difference between a social worker in your role and a patient navigator? I think sometimes people might get those confused because they see each one, well, they provide resources, but what would be the key differences there?
So patient navigator kind of like points together with resources, but I feel like with social work, we kind of assess more deep down of what's the problem or what is the kind of barrier, and look at it kind of from all different angles. And then just try to see if we can solve different aspects, or see if we can get to a solution through a different avenue. And then also kind of helping with that coping piece, because there is, while we get all this information, it's like we don't know where to stay, or this is financially draining. How much stress is that being put on a person or a family? So just kind of touching with that emotional aspect or the coping aspect of that kind of sets us apart from kind of patient navigators. We do a lot of kind of patient navigating as well, but touching in base and just kind of digging deeper with those assessment skills. So like, for example, someone having issues kind of like, well, I am having trouble with kind of finding places to stay, cost of travel so much. So if I can kind of point like, well, actually this resource over here can kind of help out with your cost of travel and maybe a few days of like lodging, would that maybe help you reallocate your funds a little bit to extend your stay or to kind of find a place that you're more comfortable with?
Thank you. I really appreciate that clarification. I think a lot of the patients do too. Dr. Shetha and Dr. Gambos, I have a question for you. We are about 10 minutes away from closing this session. But when patients come to you, I think sometimes they can be very overwhelmed and they don't know exactly what questions to ask in regards to how you are going to help them along their journey or what next steps they should do. So I was wondering if maybe both of you could kind of just hit on what are some of those top questions you think patients could be asking you or could be asking their the members of their own teams back in their respective countries and states.
Dr. Chef, you want to go first?
Sure. So a lot of the times when we're seeing patients, it's for directed therapies. And so I think the most common question I get is, what question should I be asking? So this is it's a common question for us to hear. So for us, a lot of it is sort of expectations in terms of, first of all, what is this procedure you're planning? And what should I expect during the procedure and afterwards? And so we spend a fair amount of time just going over the concepts behind it, and the procedure and the approaches, because it's, I think some people kind of have an understanding of, well, this is surgery, you open somebody up and you take it out. I kind of get that. But what is this, image guided, minimally invasive? What does that really mean? And so being able to sort of, talk them through the approach that we have is, I think, the most important thing that they're looking for. And then the other is the, the recovery process and the follow-up. So just like Dr. Gambo said, with these patients, we need to have eye exams. It's the same with us, except our exams are with imaging. And patients just need to have routine imaging. And what can we do if we see that the tumor is still there or it's come back after several years? What are our options that we can offer for that too? So it's nice to kind of lay out that roadmap from the very beginning, so that we kind of are on the same page about expectations.
So, my perspective is oftentimes I'm the first interaction with this journey, and I'll call it a journey because cancer really is a journey with many years and interactions. The hard thing, and with almost all the tumors that I deal with, is they're rare. So sometimes people prior to coming to me have interacted with other great clinicians, but they've been hesitant to use the word cancer. It requires, a comfort level to make that difficult diagnosis, and it always is associated with 1,000 other questions after that. And so most clinicians who aren't cancer specialists then sort of let you defer, say, well, go see this doctor and they'll explain it all to you, and they'll either say it's cancer or not. And so one of the things that I think really is unique and common, ironically, in my practice is everybody has a rare cancer. The rareness is relative, but these are things that are difficult to sort of come to grips with, because people say, I never even knew you could get cancer in your eye. It's just sort of beyond concept of how this happens. People are comfortable with the concept of breast or lung or colon, but the eye, it sort of makes no sense at all. Then it's sort of finding someone who's comfortable enough with this rare scenario. And then a lot of times they don't know what to ask, because for many patients, it's cancer always equals death. And that's not true. Cancer doesn't always equal death. We have a whole institution that proves that's not the case at all. But it's certainly overwhelming. And I think that these sort of support environments are useful for certain patients who need that support and can benefit from that support. At the same time, I always caution patients and say, you have to be careful on chat lines, because your situation is unique to you. Same tumor in a different size, different location, different prognosis. You can't package this and say, the person that I met online said that they have this. Why aren't you saying this about me? Everyone is truly unique. Everyone truly has a different scenario. For uveal melanoma, intraocular melanoma, it can be the size, it can be whether there's fluid, it can be all these little features that determine whether, when I meet you for the first time, I say, let's watch this or let's treat this. Also, I am inherently an optimistic person, but I am also very transparent. I never want a patient of mine leaving my office saying, I feel like he wasn't straight with me. I feel like he wasn't 100%, straightforward, or he's hiding something from me. He doesn't want to give me the real bad news. And so my style, which I hope works for my patients, but, may not work for everyone, is very, this is what we have. This is how we're going to treat you. And this is how we're going to move forward. And we're not going to sugarcoat things. And I promise you, if there's an answer or there's a treatment, I'm going to find someone, hopefully in my institution, but if not somewhere, who's going to provide you with the care that you need. And we're going to go through this journey together. And it's going to be a multi-year journey. I mean, I have patients who are still with me, almost 20 years since I started at Anderson, and that journey goes on. And it's wonderful to see them 20 years later and to see their family experiences and all that. But as Alan has pointed out, for some people, it's very hard to feel that they're alone and isolated. And I can assure you that they're not, that there is an environment and a community that's out there. And ironically, as rare as uveal melanoma is, trust me, I have cancers that are way more rare than that, there's everything is a bit relative. But these sort of environments are very helpful. And I think you just need to find what you can out of it. And if it's meeting another person who's lost their eye, or meeting another person who's had protons or a plaque or something like that, I mean, that's where it can be really helpful.
Thank you. Thank you all. So we are almost out of time, and so I just need to wrap everything up. So for everyone who attended and asked questions through the chat, we really appreciate it. Just a thank you again to Dr. Gombos, Alan, and Dr. Sheth. So appreciative of your time and being able to talk about MD Anderson and about your specific professions and how you impact the OM team there. And hopefully everyone is able to take some pieces of that back with them. Just a reminder for everyone that after this session, there is another session on the main stage. It's all on hope with metastatic OM patients that Canada has led, and it's really impactful and exciting. So please see that. And then also we have live sessions starting tomorrow at 10 a.m. all on the main stage. So thank you so much for all of your time, and we will see you all later.